Hello everyone, and welcome to another Case of the Month series. Today we have an 18-year-old boy who seeks medical care because he states that he's had fever, weight loss, and lower extremity pain, and he's noticed parietal and sternal soft tissue masses, and that these have been present for like 3 weeks. And the recent development is that of an axillary mass. And then what we do is we do an initial blood workup, and during the initial blood workup, pancytopenia is discovered, and the patient undergoes a bone marrow biopsy. Now in the bone marrow, you can see that the marrow space over here is infiltrated with neoplasm, and as you move further, you can see areas of hypercellular, more conserved bone marrow tissue as well. When you zoom in, now I'm going to zoom into the neoplasm. There we go. You can see like these sheets of cells, which are well, part discohesive, but then one might say that there may be even cohesive at areas. They've got these sometimes these compact island-like growth pattern, and what's noticeable is that most of these have a very prominent nucleoli, as you can see here. There are a lot of mitotic figures as well. I'm going to zoom in now. Some of them have lobulated nuclear contours, like so. Some of them have reniform nuclear contours, like this one. Most of them, as I said, have prominent nucleoli, some of which are more like central and really large, some not. Some of them, you can see that the nucleus is actually eccentric, and has some sort of a more like rhabdoid appearance, whereas others are reniform, kind of resembling the hallmark cells of anaplastic large cell lymphoma, which immediately, of course, pops into mind. When you move towards the relatively intact bone marrow space, you can also appreciate the intrasinusoidal growth pattern of this neoplasm. Over here, you can see that they've dilated the sinuses and are infiltrating within them as well, which is also, of course, a feature you can see with anaplastic large cell lymphoma. So initially, we do an immune panel directed against a spectrum of entities, and we put in CD45 for lymphomas, of course. We put in SAL4 for germ cell neoplasias, S100 for melanomas, Desmin for rhabdomyosarcoma. We put in WT1 for CIC rearranged sarcomas, which we initially consider in the differential diagnosis. And we also put in CD30 because this does resemble anaplastic large cell lymphoma, and we know that it can be negative. So amongst this, within the initial panel, I'll show you the CD35, by the way, here. The CD45, excuse me. The whole panel that I've just mentioned to you is negative, including CD45, which should not sway us away from anaplastic large cell lymphoma. So we should always consider it when we see a neoplasm like this in a young patient, because CD30 is positive. Over here you can see, and in fact it shows that the neoplasm is actually really well demarcated from the bone marrow tissue, almost like a metastasis. But then when you move further to this area, CD30 also highlights that intrasinusoidal growth pattern, which actually helps a lot, not just those hallmark cells, but that growth pattern also helps with the differential of with considering the differential of anaplastic large cell lymphoma. So we do a second immune panel where we put in all the T cell markers, the CD2, 3, CD4, CD8, and cytotoxics TIA and ALK and EMMA. And you can see that this neoplasm is ALK positive, beautifully stained for ALK. And within the T cell markers, it's only positive for TIA, which proves the cytotoxic origin of these cells, as you can see here. And with this, the patient is diagnosed with anaplastic large cell lymphoma. Later workup also reveals generalized lymphadenopathy, and the lymph node, one of the lymph nodes of the patient is also sampled, where we get the same diagnosis, ALK positive anaplastic large cell lymphoma. So mustn't forget to include CD30 into a panel of undifferentiated neoplasms, even if CD45 is negative. I think that's what this case teaches us. Thanks for listening. Hope you enjoyed this case. Bye-bye.